Good morning, everyone. Welcome back to another HRG Outbreak Outreach webinar. Hopefully your communities are continuing to return to normal, even if it is a new normal for you all. As we continue to navigate COVID-19, HRG is committed to sharing industry updates and best practices each Thursday morning, so make sure to join us. Before we get started, just a couple housekeeping items. To make sure that we honor the time we have allotted today, we will answer any questions that come up in an answer sheet that will be sent out later today, with a remainder of the webinar resources, including the slides and the webinar recording. Since the beginning of this pandemic, there have been so many changes to the telehealth billing guidelines. It can be incredibly difficult to keep up with these changes, so we are very glad to have Megan Smith, our Executive Director of Training and Quality, back with us this morning with a follow-up to her previous presentation on billing for expanded telehealth services. Megan, go ahead and take it away.
Great. Thanks, Taylor. And good morning, everybody. We're going to go ahead and jump right in. I appreciate you joining me for the second time to talk about telehealth. There have been many changes. Actually, most recently, about a couple of weeks ago, they made some more significant changes to provide more opportunities for facilities to get revenue and also see patients from the comfort of their home. So we're going to go ahead and get into some of those changes now. Okay, so starting off, let's talk about just some key industry terms. And I think we all know this, especially since those of you that are logging in for the second time to talk about telemedicine, but really telemedicine is kind of an umbrella term. There's several services that kind of fall under that category, ranging from the patient sitting at their home or sitting at a health site over the phone. We've also got audio only telehealth, virtual check-ins, e-visits. More specifically, we're going to focus today a lot on the originating site and also the distant site and some of the changes that have happened in March and also April as a result of the public health emergency. So let's talk about some of the things that happened in March. Okay, so many of you have probably heard about the waiver 1135. That relaxed a lot of regulations around and kind of the guardrails around telemedicine. Some of the biggest things was the originating site restriction that was waived. So previously, as you know, patients were required to go into a healthcare facility. Going into that healthcare facility allowed that clinic or department to bill as an originating site. Now they don't want patients to leave their homes for obvious reasons. They don't want to pose a risk to themselves or others in getting the COVID virus, and so they want the originating site to be the patient's home. Fee schedule additions, so to help support the patient receiving visits from home, they added 85 more services back in March to the telehealth approved list. That was a big change. There were several things, including emergency department E&Ms, home visits, home health visits, hospital discharge, things like that that weren't previously thought of as a telemedicine visit. The patient prior relationship was waived for telehealth. And then also is kind of that ties into this, the in-network and out-of-network benefit for managed care plans. Medicare advised that those would be paid one and the same. So a patient could reach out to as a new patient to an out-of-network provider and still receive the same benefit level. Providers could begin to use additional audio and video technology. This includes things like Skype, Apple FaceTime, Microsoft Teams. This came out from the Office of Civil Rights. They said that they're going to be waiving potential HIPAA penalties for good faith use of these non-public facing applications, which is huge. There are some public facing applications specifically called out that you couldn't use, and that would be I believe it was Facebook Live and also like TikTok, things like that. That's not something that you would be able to use because it's not HIPAA secured. Also, CMS waived the video requirements for certain E&Ms. So they would allow the patient to receive a certain list of services, and that is published out on CMS, but they would be able to receive these services over just using their phone rather than that audio and video requirement. It looks like I missed a bullet here. Flexibility to reduce or waive the cost share. So CMS sent out a memo to the managed care plans advising that cost share related to COVID-19 testing or E&Ms that result in a COVID-19 test, they would be waiving that cost share for the patient. And so Medicare would be reimbursing 100% of the allowable for that visit, and there would not be that carve out for that patient cost share. And then probably the biggest, which helps support our RHCs and our FQHCs, is previously the requirement they would not be able to bill as a distance site. And in March, late March, they changed that and they said that, hey, you know, we realize that you're losing a lot of revenue. We also want you to be able to see these patients. And so we know you're losing your originating site revenue. You can now bill as a distance site. During our last presentation, I focused on that quite a bit, but we did not at that time have billing instruction for how to bill as a distance site for these additional facilities, but now we do, and I'll get into that in just a little bit. So moving on to some of the changes that happened in April, and this was kind of late April when I noticed these ones. I think it was there are two specific MedLearn special editions, and I have the numbers here on our resource page. They continue to update those, and by they I mean CMS. And so there's a couple of them that they're adding in more regulations, they're adding in more billing guidelines. They're two super helpful documents. So like I said, I do have the numbers and also the reference links on the resource page. And I highly recommend you keeping those as a favorite somewhere and just continue to check in on that. When they do make changes to those documents, it is highlighted in red, and they typically have up at the top the revised date. So some of the things that happened in April, and this is pretty big because when March, and I'm talking about bullet number 1 here, when they expanded the practitioners to include your PT and OT therapists and also your speech language pathologists, these services specifically were called out in March as things that were not appropriate to be billed as a telehealth. Well, they're deciding that this needs to happen. These patients can't go in, they need their therapies, and the patients can't go on site to receive those. And so telehealth is appropriate to provide these services. So to support that and support that revenue of those therapists being able to provide the service over telehealth, bullet number 2, and this is pretty big in my opinion, they are allowing providers to bill, so your hospital outpatient departments can now bill as an originating site while the patient is receiving therapy services and is registered as an outpatient. So what I'm talking about here is your reoccurring visits. So under this new expansion for the providers that can provide telehealth, you can bill as an originating site if the patient is admitted as an outpatient in your hospital outpatient department, your HOD. Starting May 1st, they're receiving the physical therapy services, their occupational therapy. You're doing it over telehealth. You're discharging at the end of the month. You can bill each one of those visits as an originating site during that month span because the patient is an outpatient registered for that reoccurring visit. I have been scouring the websites to try to find some billing guidance. I'm going to continue to look, but I'll have to send that to the group or whomever is interested as kind of a follow-up because this just came out about 10 days ago from what I could find on the updated CMS website. And so I don't see any specific billing instructions at this time. So I'll go ahead and take a look, but I'm certain there has to be to be able to bill that Q code from that HOD, you're going to need to have some sort of a modifier, which it could be modifier 95, but I want to double check before I send anything out to anybody. So they also expanded in April the reimbursable audio only services. So going back to that expansion in March where they said, you know, you don't have to have the video and the audio in order to provide services telehealth. Like I said, there's a specific list. They also added behavioral health and education services. This last bullet here, so to address the workforce concerns, CMS is waiving requirements to allow physicians whose privileges will expire. They're allowing them to continue practicing. They're also allowing new physicians to practice before a full medical staff review and approval process. So they want to make sure that we have the workforce in order to provide care to our patients. And that's just kind of generally speaking, but also applies to telehealth services. So this is where the rubber hits the road here. So this is how you're going to bill your distance site. So critical access distance site billing, there really isn't a big change because critical access hospitals were able to bill as a distance site previously. You do have a slight difference in your general billing between method 1 and method 2, but I think the biggest change, and really the only change right now during the public health emergency, is a pending modifier 95. So CMS right now is requiring critical access hospitals to put modifier 95 on your telehealth services. And then also your place of service. Now they will accept a 02 for telehealth. They're not saying that you have to change that. So your traditional telehealth services can absolutely bill out as a 02. That's okay. But also under bullet number 2 on this top box here under method 1, they do want the place of service to be the same as it was if you were not in a PHE situation. So if it's not a service that you would have normally provided over telehealth, but now you're allowed to do it because of the expansion, you're not going to use the 02, you're going to use the place of service that it would have been normally. Okay, so RHCs, so this information came out a couple of weeks ago, or maybe 3 weeks ago, and maybe it was around mid-April or so. So what they've done is they've changed the billing guidelines just a little bit based on the data service. So they're going to allow distance site billing to go back for an RHC back to dates of service of 1/27/2020. They're allowing you to go back and bill for that. I'm not sure if any of you guys have dates of service because you weren't technically aware that an RHC or FQHC could bill as distance site, but you never know. You can go back to that date of service. You need to bill that on a UB with a standard type of bill of 71X. You're going to use your standard revenue code, but you're going to use this G code, G2025, which indicates that the services were furnished over telehealth. You're going to put on your CG modifier, and then modifier 95, which is different from your critical access hospital. For your RHCs, they're saying that modifier 95 is optional. I think they're adding it in there as optional because they want you to be able to do a one-time program of your system to put on the appropriate modifiers, and you don't want to have to change it. So if they change their billing guidelines and they start requiring modifier 95, in my opinion, you might as well set it up now because they're saying it's optional. It's not going to cause any problems if you send that modifier to CMS, and at some point they may require it. So I always err on the side of caution and just put it on there. So dates of service after July 1st, that's when it gets a little bit easier. Let's see, you're not actually, really the only difference is you're not going to put on the CG modifier. You're still going to use the same type of bill on your UB. Your revenue code's going to be the same. You're still going to use that G code, and modifier is still showing as optional at this time. But like I said, that could change. So in my opinion, you might as well add it on there to make your life easier if 2 weeks from now they start requiring it. Okay, so for FQHCs, this is also broken out by data service range. So they are still going back to 1/27/2020 through the end of June. They want you to bill it on your standard UB04 type of bill, 71X. Your revenue code 052X still going to be the same as what you would use. You're going to use one of your, you're going to actually have 3 codes on your claim here. You're going to have the applicable G payment code. You got to have that on there. You're also going to have your HCPCS or CPT that describes the services that were furnished to the patient. And then you got to have the G2025, is like what we indicated on that last slide, that indicates that the telehealth service was provided to the patient. They do require a modifier 95 on your FQHC claims. And you have to put that on your HCPCS and your CPT that describes the services, and you also have to have it on your G code. So as an example down below here, I've got, this is a screenshot taken directly from the CMS guidance. So the MedLearns special edition that came out and has been updated. Right here just kind of shows you how your basic claim's going to be. You've got your G payment code here, your 0467, and then you've got your 99214. Going to put that modifier 95 on there, and then you've got your G code to indicate telehealth services, 95 modifier on that one as well. And remember, this is only for dates of service from 1/27 of this year through the end of June. So services after July 1st for your FQHCs, you're going to bill that a little bit easier, basically. So all you got to do is include you're still going to use the same UB, still same type of bill, same revenue code 52X. Your HCPCS is going to be the G2025. So you no longer have to include the G payment code, and you don't have to include your HCPCS or CPT code describing the service. You really just have to put that G2025, and they're showing that modifier 95 is optional. So it goes from being required to optional. So kind of back to the same thing. If you put it in now because it's required, I would just leave it in there, your modifier 95, because they could change it once again, and you don't want to spend the time to go back and say, you know, we don't want it on claims anymore after July 1st because it's no longer required. One thing that I do want to point out, and this was indicated on that CMS document, for services that were provided at an FQHC as distant site. So over the last few weeks, so once the information came out from CMS that said, hey, you guys can bill as a distant site, you were seeing patients, you were generating that revenue, but weren't really sure how to bill those claims. So in some cases, some services may have been provided that were not FQHC qualifying visits. CMS is recommending that if you provided services before July 1st that were telehealth that did not include a qualifying visit, you should hang on to those. They want you to hang on to those. They want you to bill those under the new way of just the G2025 after July 1st. And that comes directly from the CMS document. So I would hang on to that. Like I said, links on the resource page at the end of the presentation, but they're telling you to hang on to it. That's going to ensure that your claim gets processed and paid appropriately. So just a little bit more information on how this is going to be paid. So because the changes in the policy were made on an emergency basis, allowing RHCs and FQHCs to see patients as a distant site provider, CMS does need to implement the changes in their claims processing system, which is why they also have that date. They should have their system updated by July 1st, 2020. In the meantime, if you are submitting your claims, you are going to receive an all-inclusive rate as reimbursement. However, the telehealth visits are not going to be reimbursed at the all-inclusive rate. They're going to reimburse $92.03, which is the average of all fee schedule telehealth services weighted by volume. So they need to update their system. That's supposed to happen starting July 1st. The system should be updated for all incoming claims at that point. They're also going to go back and reprocess all of the claims that were paid at the all-inclusive rate. So if you submitted your claims as a distant site and you were paid at the air, then those are going to be reprocessed. My advice to you would be to get a report pulled, make sure that you have kept track of all of those claims that you billed as distant site that were processed and received the all-inclusive rate, so that you can make sure to go back that they were actually reprocessed and you got that $92.03 for those services. Okay. So my last slide here of kind of instruction is regarding the CS modifier. So there's a couple of modifiers related to the public health emergency that are kind of floating around. There's a lot of documentation on these modifiers specific to telehealth billing. Now they're saying that you should not use the CR modifier, which indicates that it is crisis related. That is not required for telehealth billing and all the changes under this type of waiver. And the way that you can tell which modifier is needed is based on the type of waiver, whether it's a blanket waiver or it's the type of waiver for the telehealth. So I encourage you to take a look and see the types of waivers. There's a lot of resources out there. There is actually, and I believe I linked it to the back page. If not, I'll make sure I get it to you guys. There is a really nice description of all of the waivers that have come out since the public health emergency was declared back in March. And it describes the types of waivers. It doesn't give you the billing guidelines necessarily, but then knowing the type of waiver will help you to discern which modifier is required. So the CS modifier, that is one that you do want to use on your telehealth claims. CMS, and kind of going back to what I was talking about in the beginning of waiving the cost share for patients, CMS is going to pay all the reasonable costs for E&Ms and services that result in an order of a COVID-19 test. So the way that you let CMS know that there should not be a cost share applied and you should receive as a provider 100% of the allowable charge on that is you're going to append the CS modifier. So there is direction saying that RHCs and FQHCs, they need to waive the collection of the coinsurance from the beneficiaries. They're going to put that CS on the claim service line. Okay, so you can set that up when you're putting your charges on your claim. You can also set that up in your EDI scrubber to recognize the list of charges that should, or that where a patient cost share would apply. I would recommend doing that so it's done in an automated fashion so that you're not having your billers comb through, or somebody at the facility comb through, you know, which one of these actually results in a test. There is a specific list out there, and you can append your CS modifier to those, and then your claims will be processed correctly. Claims paid with a coinsurance applied, so claims that did not have the CS modifier on there, where it did indicate a patient out of pocket, because remember, all of these regulations and changes are happening very quickly. In the meantime, providers are seeing patients and they need to submit their claims timely, and they need to get that payment on the charges. So it's very possible that there are claims that were paid with that coinsurance applied. Those are also going to be reprocessed as of July 1st. And similar with the distant site for your RHCs and your FQHCs, I would make a list, pull a list of all of those claims, make sure that they get reprocessed appropriately, make sure that you have those claims on hold. If you have a patient responsibility that you're statementing the patient on, you're not going to want to do that, because those are going to be reprocessed and the patient shouldn't be making those payments. I think that's just going to save you a lot of heartburn on the back end on having to process those refunds if you just hold off right now and just know that CMS is going to reprocess those. So that kind of wraps up, you know, the billing guidance that I have. A lot of information in these slides. We're going to go ahead and share it with you guys. But one thing that I wanted to talk about just really briefly at the end here is there's a lot of information that's been coming out, and probably a lot of you, like me, subscribe to listservs. So I'm on no less than a dozen lists, and I get a lot of information coming into my inbox, and it can be tricky sometimes sharing that information. So you get it, you review it, you digest it, and then you decide what needs to go out to the different departments. And what I was doing internally is I was flying out summary emails sometimes 3 times a day to some of my internal folks, like, this is all good information, it's great billing information, you should know this, because I want to make sure that we're taking care of our clients. But what happened is they were getting update fatigue, and then really quickly folks started ignoring the emails, not on purpose, but really out of survival, because there's so much information in there. It just takes a long time to get through it. So in our training department, we use a lot of infographics, and you can see one here on the screen on the left. These are, I think that these are a lot of fun. They're really cool to look at, and you can add in a ton of content, and it's just a single page. So folks can you know, put this on the side of their cubicle wall, or they can have it saved in a OneNote to just kind of refer back to when that situation comes up. So at HRG, we create a lot of infographics, whether it's way not as busy as this one here. We have much more simplified ones for like our self-pay group, for scripting, things like that. This one on the screen here is more specific to the telehealth billing. And so everything that I just went through in my previous presentation is actually captured here on this infographic. Talks about things that happened before the PHE declaration, some changes that happened afterwards, a couple of details on distant site for RHC and FQHC. That's important because they weren't able to bill that way before. And then all of the billing instructions for billing as a distant site, all the way from your cause down to your FQHCs. So this is a really cool tool, and it's something that we'll share with everybody at the end of the presentation when we send out our follow-up email. We'll be able to share this infographic with you, but I highly encourage, whether it's an infographic or just a really quick tip sheet, saving something like that out on like a SharePoint site. So it's something that we've been growing internally quite a bit at HRG, is our SharePoint site. And there's a lot of options that you can do with SharePoint, but I think the best thing is that each one of these CMS documents, you can save a link out there, and then you can just send the link out to your internal group to say, hey, you know, here's a brief summary on what that link is. when you get a chance, this is what's pertinent to you. When you get a chance, go ahead and check it out. That way, my billing directors and folks that I work with, they don't have to read through my 4-paragraph email, because I think all of this stuff is so important, but they just quite frankly don't have time to read through it. So between the infographic and having a repository with all of the pertinent information, all the CMS releases, that is like their one-stop shop, and that really does ensure the success for their billers and really ultimately for our clients. So, okay. And I can't say enough about SharePoint. I'll tell you, it's a good product, and it's an excellent resource tool for your internal teams. A lot of opportunity there. All right, so just kind of wrapping up, here's that resource page that I referred to a couple of times. I do want to point out bullet number 2 and 3, those are those specific MedLearns, the special editions. 20011, boy, that thing's been revised at least 3 times. A lot of information on that one. And then 20016, that's going to give you specific information for your FQHC and your RHC distant site billing. It's got all the requirements in there that I put in my slides, talks about the modifiers, and that is the document that tells you need to hold on to your FQHC claims if you did not have a qualifying visit when doing telehealth prior to July 1st. You want to hang on to those and then submit them after July 1st to make sure you get paid appropriately. So with that, I am all done here. I'm going to go ahead and turn this back over to Taylor.
Thanks, Megan. Such great information you shared with us. We have something new and exciting for you all starting this week. To stay current in healthcare today, HRG will be interviewing industry expert leaders in our new podcast, Revenue Cycle Review. Our goal is to provide a source for revenue cycle tips and hot topics. Tune in to learn best practices, industry insights, and healthcare innovations. Episode 1 is posted on our website and available now on Apple and Google podcast platforms. We will have new episodes every other week, so be sure to check it out and subscribe so you don't miss anything. If you could switch to the next slide for me, Megan, that'd be great. Awesome. We will be sharing, like usual, the webinar recording and slides in an email later today. Included in that email is a link to a survey. We really appreciate you guys filling out these surveys. We've actually taken a lot of the ideas that you're sharing with us and the speaker feedback and giving that back to our team in order to continue to create content for you guys, which is why next week we are going to be having our Executive Director of HIM, Teresa T, and our Executive VP of Out Partnering Center, Jason Coffin, to discuss successfully managing remote teams. If you guys have any questions for us, please continue to either just shoot me an email and I will get those to the right person. And with that, we will see you next week. Thanks so much for joining us.